Welcome, everybody. Let everybody come in from the waiting room. For whatever reason, that always takes a minute. All right. I think everybody in the waiting room is in and people can trickle in. Well, good evening and welcome, everyone. I'm Rachel Rosen Simpson. I'm the program manager here at the Breast Cancer Coalition. I'm so glad that you could all join us this evening to learn more about exploring psychedelic-assisted therapy in cancer care with Dr. Rob Horowitz. We are grateful to the Lisi Rosenthal Memorial Education Fund that supports coalition educational offerings like this one. We couldn't do it without that support. Before we begin this evening's presentation, I always have a few housekeeping announcements to share. First off, I'm excited to announce that we have two other special guests with us tonight, providing ASL interpretation services for our deaf and hard of hearing community members. So please welcome interpreter Alana and interpreter Kaylee, who are joining us as panelists tonight, and they will be spotlighting on and off. This is my first time doing this, so I hope you'll bear with us as we try out these settings. But as a part of our coalition strategic plan, we will continue to include ASL interpretation services moving forwards during all our evening webinars, and I'm very excited about it. So, also, closed captioning is available if you click the little CC button at the bottom of your Zoom screen. So you have many modes to help you fully experience this webinar. If you missed the link in the Zoom reminder email for accessing a PDF of Dr. Horowitz's slides, if you'd like to follow along with his presentation, I'll drop that link into the chat for anyone who would like it. I'll do that right now. Right there. And I will facilitate a question and answer session following the presentation. So please type your questions into the chat function at the bottom, and I'll continue to compile them as the presentation unfolds. So as they occur to you, type them in the chat, and I will compile them, and then I'll share them at the end with Dr. Horowitz, and we will answer as many as possible before we try our best to wrap up by 8:30. So just a disclaimer too, that Dr. Horowitz cannot give any specific medical advice for an individual case during this short time that we have together tonight. So if you could try to keep your questions broad and inclusive of others, that would be very much appreciated. If you want to watch the presentation again, it is being recorded and it will be added to our webinar library on our website, as well as uploaded to our YouTube channel. So I will drop those links into the chat for the webinar library and the link to register for future webinars into the chat as well. And then at the end or whenever you leave, a short survey, it's only 10 questions, will pop up on your browser. And we do utilize your anonymous feedback when planning our future program offerings. I promise I read everything. So please complete the survey and help guide us in the future if you're willing to give us any feedback. So without further ado, tonight's webinar features a very special guest and friend of the Breast Cancer Coalition, Dr. Rob Horowitz. Rob is the Georgia and Thomas Gosnell Distinguished Professor in Palliative Care. He is amazing in that he is board certified in internal medicine, pediatrics, and hospice and palliative medicine. The overachiever, Rob. He was chief of the palliative care division at Strong Memorial Hospital from 2015 until 2023. Earlier in his career, he founded and directed Rochester's adult cystic fibrosis program through 2015, and also spent 14 years working as a rural emergency physician. In addition to his clinical work, Dr. Horowitz is deeply committed to teaching. At the University of Rochester School of Medicine and Dentistry, he helps train multidiscipline students, residents, and fellows in palliative care and communication skills, which is so needed. I'm sure you'll all agree. Together with his colleague, Dr. Tom Carroll, he created the Advanced Communication Training, ACT, which is a program at URMC, which helps clinicians learn how to have meaningful, compassionate conversations with patients and families facing serious illness. In 2023, Dr. Horowitz introduced ketamine-assisted psychotherapy, which is also known as KAP, to URMC for people living with serious illness, which includes cancer. And we will learn about this program tonight and hear more about the incredible successes that that program has brought to our community over the past 3 years. We are thrilled to have Dr. Horowitz with us and to welcome him tonight. So without further ado, take it away, Dr. Horowitz.
Thanks so much, Rachel. Am I audible? Am I clear?
You are.
Hearable? Okay. All right, let me get the screen set up. Isn't that visible okay?
Yeah, that looks perfect.
Okay, great. All right. Well, thanks. Thanks for that sweet intro and your warm and welcoming nature, Rachel. I really appreciate it. It's a pleasure to be here to talk about something that's of great meaning to me and many of the folks we take care of here. So, yeah, as you say, without any further ado, I will strive to stick within our roughly 60-minute agreement for the presentation. And since I can't see the audience, here's honestly my trigger warning. We're talking about some really sensitive stuff here, and we're talking about uh, what you'll learn more about psychospiritual distress, depression, anxiety, trauma. And it might be that some of what I talk about, what we talk about here, uh, activates anxiety or fear or discomfort. So please take good care of yourselves. And if I'm touching on anything that feels too much at the moment, feel welcome to take a break, to step away. Um, I am asking Rachel to help channel your observations or concerns so I can address those as graciously as I can without being able to see or hear you, though. I'm depending on you to take really good care of yourselves. That is part of this healing work. So I'll start with something of a disclaimer here, noting the psychedelic hype. And I know how my enthusiasm, and Rachel can testify to that, can get in my own way sometimes. And I don't want to overhype this thing. These are some of the many, many advertisements, direct to consumer and otherwise, talking about the potential for ketamine and other therapies to help cure everything. And it bears some caution for all of us as patients, as consumers, to be wary of some of the advertising. Here is a picture of a ketamine-assisted psychotherapy program out in the community, which is really direct to consumer marketing using keywords that have been proven by AI to be powerful, to draw people in, breakthroughs, empowerment, mind-altering, neuroplasticity. Buyer beware. Here is an ad which really rather strikingly represents the potential for social media to talk up the possibilities of direct-to-consumer at-home freedom kit. You get to watch this bright-eyed woman opening her at-home ketamine use like you might open a toaster or a book. And this is a lot more important that we take great care. At the same time, depending on where you come from, you may be fueled with psychedelic horrors. I grew up in the 60s and 70s, and I learned early on, gosh, I must have been in fourth grade when I learned that this is my brain on drugs. Don't do it. And I learned that LSD and other drugs might ruin my reproductive potential, might make me insane, might turn on me instead of turning me on. Um, be cautious about the horrors as well. There are real harms. There are real harms in the psychedelic realm, including psychedelic-assisted therapies. This cover story article in the New York magazine called Power Trip documents people's being victimized by practitioners, taken advantage of, manipulated, even raped when under the suggestible, vulnerable circumstances of ingesting a psychedelic medicine. Many people, when I talk about ketamine, the first name I hear about is Matthew Perry's, who died with ketamine in his system. I really want to have a balanced approach here and share upfront some core take-home points. So let me lead with these. Psychedelic-assisted therapy, and I will be focusing on KAP, ketamine-assisted psychotherapy, where my expertise resides. It's a powerful tool, but it's not a cure-all. It can help some people, but it is absolutely not right for everyone. It can be safe in expert hands, but when done poorly, it can cause harm, grievous harm, and it rests on rigorous program planning and thoughtful patient deliberation. We really share a compact in doing this well. So my agenda for our 45 to 50 minutes of presentation are the following. Why are we talking about psychedelic-assisted psychotherapies in KAP, particularly in the space of cancer care? I'll share a whirlwind tour of psychedelics history and a whirlwind tour of some of the psychedelic science. We could spend hours or days. There are whole symposia devoted to both of these things. I'll talk about why ketamine specifically in the space within which I work, and I'll tell you about our program. It's called Pal-KAP, which is an abbreviation for palliative ketamine-assisted psychotherapy. I'll share some patient stories, vignettes about them with their permission, and then we'll close with conversation. And again, Rachel will be your channel, okay? So why are we talking about this? So this notion of psychospiritual distress, it's a big word. It is what it looks like. And what I mean by that word is any upset, whatever degree in our emotions, in our thinking, or in our sense of meaning and connection with others. And what does it look like? Well, these are a few depictions of what psychospiritual distress may look like. What triggers it? My goodness, challenging diagnoses, challenging therapies, our life histories for sure. So our story of Pal-KAP looks at people with psychospiritual distress in the space of serious illness. And I'm going to introduce you to a number of people and their stories, some of them anonymized, one of whom came to us because of a highly self-critical attitude that she wanted some help with as she was making her way through serious illness. Another person whose focus was on body grief, we're calling that, and that is a sense that the body's failing her, that it's betraying her. A sense of death anxiety for many, and somebody who's bound by fear. You'll learn more about these stories just with some vignettes momentarily, but let me introduce you to Peggy. Peggy is going to just share a little bit about what brought her into the ketamine-assisted psychotherapy space, and this is with her permission that we share a few moments with her. She had lymphoma at this point in remission.
The lymphoma experience from 5 years ago was traumatic and frightening to the nth degree, and I was so afraid I was going to die. And it leaves lasting reverberations in my soul, I think, about fear of not so much of dying, but of suffering, because there was a lot of suffering in the chemo process. And, I'm grateful I endured it and that I'm alive, but it does stay with me, and there's anxiety that comes with it. Recently, I had 2 falls, which led to a brain scan, which caused, me to be very nervous about recurrence. So that was always in the background.
I imagine some of that might resonate for some of the folks in the audience. You'll hear more about Peggy momentarily, and she'll look back on her experience in a single KAP session. So first, a short history. When I talk about classic psychedelics, we're talking about those that have been most studied. LSD, psilocybin from magic mushrooms, DMT. And I need to acknowledge that any modern history, here I'm looking at about 75 to 80 years of psychedelics history rests on thousands of years of relationship between humans and plants. This actually I learned is one of Rachel's specialties, ethnobotany. Humans and plants have been in relationship and have co-evolved over millennia. And some of the practices utilized in psychedelic therapies are based in some ways on practices that have been used for ceremonial purposes, sacred purposes, socializing purposes, and healing purposes for a long while, way before Western medicine took a grasp of this. Arguably, modern psychedelics research history began in 1938. So, what is that, 85 or so years ago, almost 90 years ago? Albert Hofmann was a chemist. He worked with a pharmaceutical company and he synthesized LSD. He synthesized this from a mold. And famously in 1943, he accidentally got some of this into his system and he took a bicycle ride. This is remembered as Bicycle Day. Every year, people who are fans of psychedelics celebrate Bicycle Day. His profound experience, though, and he was a scientist, inspired Sandoz Pharma to develop LSD for distribution to researchers. It was called Delicid. It went to thousands of researchers who were investigating its potential in healing people with a range of mood disorders, other kinds of psychedelic or psychospiritual distress, as we call it. The word psychedelic is pretty new. It was named by a psychiatrist, Humphrey Osmond, and literally it means psyche-delos, mind revealing. It opens us to being able to see our mind in a different way. In 1957, a banker, Gordon Wasson, who was an amateur mycologist, he had an interest in mushrooms, took a trip to Mexico and he met a curandera, a woman, Maria Sabina, very well known, who was guiding folks in her community through psychedelic trips with psilocybin mushrooms to help them as a rite of passage in their development into adulthood and transcendent spiritual experience. He wrote about this in Life magazine, the magic mushrooms experience, and that ignited popular and scientific imagination. By the mid-1960s, there had been more than 1,000 published scientific papers about psychedelics with more than 40,000 patients, looking at its use for depression, for anxiety, alcoholism. Terminal illness was a big focus. You probably heard of Timothy Leary. You may not know Timothy Leary was a tried and true psychologist who was a well-admired researcher in psychedelics. However, in his zeal, he upset the status quo. There are some mirrors. I'll be cautious about injecting politics into our conversation, but a conservative president at the time, Richard Nixon, felt threatened by some of what Timothy Leary was saying, named him the most dangerous man in America, and quickly evolved the war on drugs, which in 1965 ended the production of LSD by Sandoz. And by 1970, the Controlled Substances Act, which was really a socio-political move, not a scientific one, ended psychedelics research for the rest of last century. Just before the turn of the century, though, the so-called psychedelics renaissance began in earnest with better science, better design, better technology, and really compelling results. And you'll see here just a sense of how from 1970 forward, the amount of papers, the number of papers has really exploded. So there are more publications about psychedelics now than there ever have been. The FDA is currently considering approval for MDMA, for PTSD, psilocybin for treatment-resistant depression, and others. So what about ketamine? Ketamine is not a classic psychedelic. Ketamine was synthesized in 1962, and I'm superimposing on that long history here. It was synthesized for use in the operating room. It's an anesthetic agent. It was approved in 1970, And there have been tens, probably hundreds of millions of doses, which have proven a couple things. One is its safety in expert hands, as well as the potential for this medicine at particular doses to elicit hallucinations very similar to the kind of hallucinations, non-ordinary states of consciousness that are provoked by LSD and psilocybin. The first KAP, ketamine-assisted psychotherapy program, I'll say KAP, it saves me a lot of syllables and time, was written in 1997, just about 30 years ago. It's been studied for depression. I'm going to show you one of these trials momentarily. A randomized controlled trial of ketamine for treatment-resistant depression is one that got an awful lot of attention. And the first ketamine infusion clinic about 16 years ago now. I'm going to distinguish between KAP and ketamine infusion momentarily as well. And in 2018, the FDA approved nasal S-ketamine for treatment-resistant depression. So ketamine's been getting a lot of press. I'll share a little bit of psychedelic science now. Some will have a lot of interest in this. Some this may be more than you wish to know. So tune in or tune out according to your interests here. I'm going to talk a bit about the neurobiology, the neurochemistry of psychedelics. So psychedelic medicines act through interactions with receptors in the brain. Here is a depiction of cells in the brain. And this is a simplification, believe it or not, of cells in the brain, looking at many different receptors. The classic psychedelics, as I mentioned, include LSD, which is taken orally, in this case, blotter paper on a person's tongue. Psilocybin, which is derived from magic mushrooms, psilocybin mushrooms, of which there are many, many different kinds. DMT, dimethyltryptamine, is one of the components of ayahuasca, which you may have heard of. Each of these three classic psychedelics operates in the brain through a particular kind of receptor called a serotonin 2A receptor. MDMA, ecstasy, which has been studied extensively as well, is not a classic psychedelic, but it works through another serotonin and other neurochemical receptor system in the brain. Ketamine is unique in a number of ways. Ketamine, as I mentioned, has been available since 1970, since it was FDA approved. It's available by multiple forms, can be injected. That is the way we generally provide that in KAP program through a shot. It can be given by IV, as it is in the operating room. It can be taken orally, can be squirted in the nose. This acts differently. This acts through a receptor called NMDA, N-methyl-D-aspartate. It works through that receptor. So you'll notice that these different psychedelic compounds, and there are dozens, really hundreds of others, act through different mechanisms when they get into our systems through the different routes by which humans can ingest them or by which we can administer them. They also share some neurochemistry. So here, classic psychedelics through that serotonin receptor and ketamine through the NMDA receptor, they initially work through different processes, but they meet up at this point where they share this thing called a glutamate surge. And again, the detail won't matter to most of you, but what it says is there's a convergence of their effect, which elicits a non-ordinary state with a lot of overlap with other psychedelic substances. And they also share the impact that downstream from their effect in the moment, they seem to provoke a chain of events in the brain that enhances neuroplasticity. And you can think of neuroplasticity as simply being the capacity to learn. So all of the psychedelic compounds we're talking about can have unique impact and a lot of overlap, and can enhance learning from experience when focused. So the mechanisms of action biologically are these medicine receptor interactions in the brain. What is the effect? So a few points worth noting. The default mode network is a complicated um, uh, uh, community of brain processes which really oversee the narrative self, the autobiographical self, the part of us that is talking about our experience, either with words or with thought. And when that's turned down, it's always on. It's on when we're sleeping, it's on as we're thinking. It's on for you right now as you're listening to me right now. And you might be noticing that you're wondering about, oh my God, what is he talking about? Or, oh gosh, I got an ache over here. Or I wonder how the kids are doing. Or what's on my shopping list. Or a worry. Or the scan next week. The default mode network is doing all of this and it's serving us, but it also can get in our way. Psychedelic medications they turn down the intensity of the default mode network. And as a result, it can reduce rumination, those thought loops that can dominate our thinking at times. And at the same time, while quieting those autobiographical thought loops, it can open us up and open our thinking and open our capacity to think of things in different ways. The strengthening of neuroplasticity really means that it opens the brain to learning. And so in the immediate exposure to psychedelic compounds, people may see things and feel things in different ways. And if thoughtfully experienced, processed, guided, may take the lessons learned forward in a lasting way. What is also clear is crosstalk across the brain expands when under the influence of these psychedelic compounds. This is a sort of cartoon representation of compelling fMRI scans of brains. This is a group of people's brains on placebo, meaning no active drug in them, and on psilocybin. And what this is showing, the density and number of connections across these regions represented by these threads, you'll see the number of those threads across brain regions increases with psilocybin. And so what this means is parts of the brain that are usually not in contact, that we're usually filtering, separating, are now communicating with one another. And that can enhance our perspective on things. It can allow us to see things differently. It is probably this that underlies something called synesthesia. Some of you may have some of this. Synesthesia is when sensory aspects of our experience are combined so that we can, for example, we can taste color or we can feel music. That's some of the biological process that can happen well borne out when exposed to psychedelic medications. What's the psychological impact? So there's a number of things. And so many studies that look at different features of this expanded openness, both emotional openness and cognitive openness and heart openness. Greater ease with grief, fear, and anger. Some people call these negative emotions, and I'm careful about that because these core emotions are necessary. They're part of our birthright, and they serve us. Grief tells us that we're threatened losing something we love. Fear tells us we're in danger. Anger is a way we protect ourselves, and sometimes these can be difficult. They can make life hard. They can be challenging to us. Exposure to psychedelics can ease our relationships with these emotions and allow us to be with them in sometimes a highly therapeutic way. One specific easing can be anxiety about death, very common when exposed to psychedelics. I'll share more about that, and Peggy will tell you something about that momentarily. A sense of connection is very common in this space, and awe, wonder, reverence for the little things. It is felt oftentimes in the psychedelic space that the little things are the big things. I will share with you, not confidentially, I'm speaking to an audience whom I can't see, but I know the psychedelic experience. I know the ketamine experience. I know each of these features. I'm careful in using my experience with psychedelics as a source of evangelicism about their usefulness, but I can speak to the power that one can experience and the healing power in this. This is one of many surveys that people can fill out about the psychedelic experience, talking about mystical experience. And while some people are turned off or excited by the notion of a mystical experience, really what this is talking about is a sense of connection, a sense of deep knowing, a sense of conviction that what matters more than anything is connection or love or transcendence to things greater than ourselves. Powerful experience in psychedelics. So I'm going to move on and share a bit about research. And I start with a couple disclaimers here. 2 words about the limits of research. One is blinding. I mentioned randomized controlled trials, and many of you will be familiar with what that means. But when we're talking about randomized trials, to get the best sense of whether a medicine is useful or not, it's important for the person taking the medicine to not know if they're putting the active medicine or a placebo into their system. And it's important for the researchers not to be biased by knowing either, because that influences the outcomes. It's not easy to blind people to whether they're experiencing a psychedelic experience. This cartoon represents that well. And if you imagine these 10 people are participating in a study, guess which 5 might have a psychedelic in their system? Or as this person says, well, so I'm guessing we're in the placebo group, sitting quietly on the couch while the others are dancing in a circle naked. So it's hard to blind, and that limits the clarity of some of the research and has been seen as a limitation, and it moves many people. I'm about to publish a paper about our program, and the reviewers demand that I be very careful in making claims because I don't have randomized controlled trial data to prove the outcomes. But I'm going to share some stories because that's powerful outcomes. Another piece of limitation in research regards inclusion. So if this is the group of people in the world dealing with, let's say, cancer, only a small number of them will qualify for any of the trials. Because in order to do a rigorous trial, it's important for researchers to ensure there is overlap in the nature of what brought people into the trial, that they have none of the potential risk factors, exclusion criteria that might compromise the outcomes of the trial. And so what the research does show is in a limited number of people within the range of limits induced by the difficulty of blinding what we might know. So I'm going to share a bit of research about classic psychedelics. 3 papers so you get a flavor for this. Each of these regards psilocybin. This first study is looking at depression in people with advanced cancer. This is from 2011 by a group at UCLA, Charlie Grobrand. Each of these, this scale here that I'm showing, is looking at a depression measure on this scale and time on this one. Those open circles represent people who got psilocybin, and the black circles are those who took the placebo. And you see those who got the psilocybin had a substantial decrease in their depression scores at 1 day, lasting 2 weeks out. And here, looking at 6 months out, still a substantial improvement in this depression score after 6 months, after 1 exposure to psychedelic-assisted psychotherapy. This study, done by a group at Johns Hopkins, run by Roland Griffiths, one of the foremost researchers of psychedelics, who incidentally died 2 years ago of cancer, and talked about his experience using psychedelics, this vaunted researcher who used psychedelics for him to deal with his progressing cancer and his concerns and fears and wonderings about dying. What he shows here is in red, people who had high dose psilocybin, in blue, the placebo, very low dose. And this is the percentage on this scale of participants who had a significant improvement in depression. at 5 weeks and 6 months out. So you'll see more than 3/4 of people had a significant improvement in depression, both immediately and at 6 months. And down here, looking at an anxiety measure. Again, the placebo group, some people had improvement, most didn't. But the group who got psilocybin dose and psilocybin-assisted psychotherapy, 3/4 of folks had an improvement in their anxiety scale immediately and 6 months out. Finally, this is a group in New York. Stephen Ross looked at other measures of psychospiritual distress, which we'll describe more in a moment. He's looking at something, suicidal ideation. This is people who were so severely ill, were overcome with anguish, and had some degree of wishing to die because of their illness and fear around it. And this shows a substantial improvement in their suicide scores, suicidality score, it's called, after taking psilocybin. And here, another measure called loss of meaning. We define ourselves by what we do, who we are, the purpose we serve in the world. And loss of meaning comes with serious illness, with aging, with frailty. This is showing a substantial improvement, a drop in the loss of meaning score in people who had a single dose of psilocybin-assisted psychotherapy. So here are 3 illustrations of the kind of research, recognizing there are limits here. And so all this, by the reviewer standards and the highest scientific standards, is called preliminary. And there are plenty of stories, again, that I'll help you understand. This is what it looks like. I'm going to show you more pictures momentarily. But here is a patient lying with an eye fold on and listening to music, lying down with 2 facilitators next to them. This is a woman named Mary Casamano, who's a well-known psychedelic-assisted psychotherapy facilitator. This is what that looks like. The research on ketamine, I'm going to share just one study. This is looking at one that I had mentioned earlier, looking at treatment-resistant depression. What this refers to is people with depression that has not been responsive to 2 different antidepressants over time. This is looking at ketamine and its improvement. This is the proportion of people who received the ketamine versus the placebo down here, who had an improvement. So what this is showing is at 1 day, this is about 2/3 of folks had a substantial improvement in their depression scores, just within hours of the medication, and it was brief. So there was a substantial improvement for about 2/3 of folks, not for another third, and it was only brief. Now this is what that looks like. This is using ketamine infusion. It's different than KAP. And I want to put these side by side and just notice the differences here. I'm going to describe these momentarily in more detail. But notice the relationship here, the medicalization of infusion over here. And I want to distinguish something because KAP and psychedelic-assisted psychotherapies are using this model. And the distinction is, and I have a couple illustrations, thinking about exercise, if our goal is to grow stronger, this now outmoded modality, which I remember from when I was growing up, people getting shaken to lose weight, it actually didn't work and they didn't get stronger. It takes effort, it takes focus, it takes exercise to build strength. If we want to get somewhere, we can use a GPS, nothing against that. But if we want to learn how to get there, we need to learn how to use the map and the compass. We can be tossed to fish, or we can learn to fish. And this kind of therapy, psychedelic-assisted psychotherapy, is around learning to fish. It's about exercising. It's about being accompanied on the adventure of understanding ourselves. So the question of why ketamine. Ketamine is unique. Ketamine is not a classic psychedelic. The research around the classic psychedelics is simply more robust because there's been a lot more of it. So why are we using ketamine? There's a number of reasons. One is it's available. It's been available. It's on our formulary. I've been offering it since I was working in the ER 25 years ago. My palliative care team know how to use it. The operating room knows how to use it. We know how to use it safely for anesthesia, for procedural sedation, for pain. What I have here, by the way, on this graph is the serum levels that might be achieved for these different purposes. For anesthesia, we're aiming for very high levels for the operating room. For procedural sedation, levels here. For pain and for psychedelic use, we're aiming way down here. We know this medicine, we have it. It's also very safe. We have 50 years of use of ketamine, and we know in medical hands it's extremely safe. It does cause effects, side effects, some of which are uncomfortable. And among these are, it can make you feel strange, feel weird in your body. It can change your thinking and communication. One can experience very intense emotions. I will say we are aiming for this. This is part of the non-ordinary state we're trying to induce in KAP. It can cause other symptoms to the body, changes in blood pressure, nausea, drowsiness, dizziness. It is not without discomfort for some, a minority of some. Major side effects are extremely rare, and we have not seen any in our now 64 sessions. Now, what about the story about Matthew Perry? So I want to put this into contrast, and I want to say with great respect for Matthew Perry, who was open about his struggle with mental health challenges, with substance use. Matthew Perry, we know this with clarity, he had a dose of ketamine in him that was higher than a standard dose used for the operating room. And he was in a hot tub. Ultimately, and this is horrible, he had a dose in him that would be enough to go to the operating room, to have his chest open for surgery without even noticing it, and he drowned. He drowned painlessly. He wouldn't have experienced it. This is so different from the KAP plan, where the doses are small and we're ensuring safety and ensuring that people don't do anything risky, including being near a hot tub afterwards. The signature of ketamine, what am I talking about here is, I'd mentioned that different psychedelics have a different impact. They feel different, although they're acting through both unique and overlapping mechanisms. They share a lot. At the procedural sedation dose and the anesthesia dose, what was discovered early on, 50 some years ago when ketamine was first being used, is when people come out of the operating room or out of the procedural sedation suite, they have what are called emergence reactions, where they have what's called a freak out. They have this non-ordinary state, and without wishing for it, it can be really dysphoric, uncomfortable, and scary. Interestingly, what we're aiming for in KAP, like in psychedelic-assisted psychotherapies, is that non-ordinary state. People are signing on for it. And when one knows one's getting it, and it's part of the process, it's more than tolerable. This study is looking at people's experience of this non-ordinary state when they have, in red, psilocybin in them, in green, ketamine, and in blue, MDMA. And these are people describing their experience, an experience of unity, a spiritual experience, insightfulness, anxiety, many other features. And you'll see here what's unique about ketamine, more reliably than any other psychedelic, is it causes a sense of disembodiment. And that's a sense of disconnection from the body. And you might think, who the heck would want that? Well, people who are grappling with who we are in our bodies, who we are in these bodies that are changing, and these bodies that we're anticipating leaving at some point as we get sicker, get older, ultimately die. This exploration of who are we in addition to our bodies is powerful. You'll hear Peggy speak about that momentarily. So we're aiming with ketamine to achieve a dose that, with ascent, gets patients to that point. What else is unique about ketamine? Well, the duration of effect. We give a shot, people have the impact immediately, and within 45 minutes to 2 hours, we can hand them off safely to a driver. Nobody drives after this, but the duration of the effect is brief enough and powerful enough to be of meaning, brief enough to leave here within 2 hours. MDMA 4 hours, psilocybin 6 to 8, LSD a lot longer. This is not to say those aren't useful, but imagine using that in a medical setting where we're trying to, sometimes with folks who are frail, who've got lots of appointments, who don't want to spend a whole day here, to be able to compress that allows persons to have the experience, to get home, and then to process the experience in due time. And finally, there's issues around equity because the costs are different as well. Ketamine, the way we deliver that in shot form, it costs only pennies, and we can write that off. When others become approved, and I'm quite confident that the FDA will approve some other psychedelics in coming years, they will probably be produced by pharmaceutical companies for a very high cost for very few people. And that is likely to price many people out of the market. They won't be able to have the experience. So there's much about ketamine that is particularly valuable here and why we favor it. So I'm going to tell you about Pal-KAP. So ketamine-assisted psychotherapy, Pal-KAP, at URMC. As Rachel mentioned, we initiated the program back in 2023. As of just 2 weeks ago, we've had now 34 people experience this. And on average for 2 sessions, some have had as many as 5 and many have had only 1 session. We developed a guideline. We were met with really overwhelming approval by a very particular board of administrative clinical professionals at URMC, which really makes us the only academic medical center in the nation offering this kind of therapy embedded in a palliative care space. There's more and more research being done here at Rochester by Bob Dworkin in the realm of use of psychedelics in treating pain. Luc Papone looking at psychedelics in cancer. Mark Swager, my colleague in the Pal-KAP program, looking at KAP for depression. And philanthropy. This has drawn attention of a lot of folks, and we've been the incredible beneficiaries of amazing generosity from a couple donors who've given now more than $1.1 million to help support the project. And the money for the clinical enterprise is helping offset the costs of offering this program so that it is more accessible to folks without much cost, if any, to them. So this is the room it occurs in. This is the pre-philanthropic investment room. And now through the magic of animation, you'll see the transformation. It's still a clinic room. I can't convince you otherwise, but the $25,000 that the philanthropist gave us allowed us to invest in these attractive sound quieting curtains, an expensive, eminently adjustable recliner that people lie on. People of any size or physical ability can get into that. We can adjust it. Chairs for the 2 facilitators. The view from the chair is here. We have art, we have adjustable sound, adjustable lighting. And behind the curtain, we do have rescue devices, which we're never going to need to use, but that gives people a sense of safety. I know how to use those. We have oxygen for the few folks who come to us who do need oxygen because of lung disease. I'm going to share a little bit about the philosophy of what we're doing here. And we think of Pal-KAP, psychedelic-assisted psychotherapy, as a healing modality. And what are we talking about here in terms of healing? I'm going to share a little bit of etymology here because it's helpful in thinking about this. Most of us don't choose to be patients, but the word patient derives from ancient roots for meaning one who suffers. We're all patients sometimes, usually not by choice. And it is a reality for all of us at some point that we suffer. What does it mean to suffer? I'm using language used by Eric Cassell, who wrote beautifully about suffering. And he talked about threat to our sense of intactness and wholeness. Cancer diagnoses do this, loss of function do this, aging does this, anticipation of mortality does this. Empathy is what happens to us when we see suffering in others. And it's experienced a couple ways. One is by the feelings we have, the emotions we have that we imagine might be the emotions of those who are suffering. We also do it by imagining. It's called cognizing in the literature, and that's putting ourselves in others' shoes. Empathy is a way of saying, I see you. Maybe I feel you, or I feel what might be your experience. The healing work provided by others, and sometimes for ourselves, compassion is taking this to the action verb, you might say. Not just seeing, but approaching, accompanying, and affirming the person who experiences the suffering. If empathy says, I see you, compassion says, I am with you. And so this work for ourselves, the patient, and for those sitting with you is to accompany you in your wholeness. That doesn't mean fixing the disease underlying. It doesn't mean curing. It means being with you in all that's going on in you so that you can recover a sense of intactness and wholeness, even in the face of serious illness, even in the face of mortality. And by that, to be whole again, to be a person and a patient. How do we have both at once is the question. And KAP aims to address that, at least to some extent. And it honors our built-in birthright, our healing capacity. It says we know how to heal. Our spirits know how to heal. We might not know that sometimes. And I'm not talking about fix or cure of disease necessarily. I'm talking about psychospiritual healing. And I'm going to quote a few folks. Carl Rogers, who is a well-known, the father of humanistic psychology, said, given the right conditions, we move inevitably toward growth. We have built-in capacity for healing. Another Rogers, Fred Rogers, Mr. Rogers, I love this. Anything that's human is mentionable, and anything that's mentionable can be more manageable. This is a space in which there are no limits to what can be talked about and addressed. Anne Lamott, a writer, incredibly moving, talks of her struggles with grief and loss and depression. I'm still every age I've ever been. In this space, we can recognize those parts of us that are young and scared, the parts of us that are still seeking approval, the parts of us that are still striving to prove ourselves to ourselves and the world. We're every age we've ever been. And Maya Angelou, who says, there's no greater agony than bearing an untold story inside you. This is a space of opening to our wholeness and our stories. So have that in mind as I walk you through the steps of Pal-KAP. The preparation session is sitting. Here is a cartoon, but we got authorization from our very first patient, Yoka, in June of 2023, who had a gynecologic cancer. Here I am, and my therapist, who was working with us at the time. This first session is about establishing an alliance and understanding. These are our goals. Learning something, psychoeducation. What are we aiming to do here? Talking about intentions and expectations in the session. If people assent to move forward, then a medicine session follows. The medicine session, I'm sitting here documenting what's going on. The medicine session, wearing eye shades, music on the ears. The elements here are medicine administration, usually by shot, eye shades and music. P, the patient noticing, feeling, and allowing. The facilitators accompanying, affirming, compassioning, right? As Bill Richards, who's a researcher in psychedelics, said, trust, let go, be open. This opens us to the possibility. So the medicine session I want to walk you through now, I can't quite simulate it, but I'm going to show you just an idea of what it's like. There are phases. There's the entering phase after the medicine administered, and moments later, there's the experience itself, and then there's the emergence phase. Just briefly to think about what that is. After the shot, the patient within 2 minutes is really feeling launched into this other space. And the presence of the facilitators diminishes. And then people are in this non-ordinary state. Now, for some, it's very dark and still with colors. And for some, it's very bright. And for some, there's imagery in there. And for some, there are faces. And for all, there's some sound. And we've done this with patients who are deaf who also experience sensation differently. We've had folks actually holding the speaker to their chest to feel the music. It may get brighter, it may get darker. People run through a range of emotions. And then 30, 45 minutes later, they're emerging back into that room, back into their bodies, present with their facilitator. And for different folks, it's that leaving this body, it's that being in that space, or it's the coming out that's most powerful. For me, I do share with you, in my experience, it's the emerging back into this body with recognition that I'm in it briefly, with recognition that community really matters, with recognition that I just experienced something and I experienced with people accompanying me, and that's really powerful. So those are the 3 steps of the medicine session. Within a day or 2 or 3 of the medicine session, we sit again and we talk about what happened. And here the purposes are to explore, to understand what happened, to make meaning of what happened, to learn. Remember, I mentioned neuroplasticity, to learn from the experience and to find ways of taking this home, to incorporate this into our being. Not the way those infusions for depression might be useful. There's a neurochemical change there. And I'm not saying that's not useful. This is not about neurochemical change. It's about having those moments accompanied and seeing what comes from that. So just a few stories. I'm going to let Peggy tell you now about her preparation, about the medicine session and the integration session. About 5 minutes here, 5 minutes with a couple stories, and then we'll take some conversation.
I wanted to get in touch with my inner self and the spirit within me in order to feel stronger in facing life's challenges. So I saw what were really beautiful shapes and colors, and also like flashes, like I was going into the constellations out in the Milky Way, very floating and relaxed, completely relaxed, and curious. I felt curious about what was next, and it was just so relaxing. I just felt like I was within my core, so relaxed. There was no pain, no physical pain. And I felt like I was going down inside my soul, like inside my body. My thoughts were going down my esophagus. And I have had a lot of esophagus problems, so that's probably reasonable that I was seeing that. And at one time, I reached for my hand to hold my own hand. And it really didn't feel like my own hand. It felt like the hand of God or the hand of my ancestors, my mom or my grandma, maybe my brother less. But it was very comforting. And even now, when I hold my hand, I feel this kind of comfort from it, which is interesting.
So if you were to tell the uninitiated, well, let's see, I was out there in the Milky Way, I went down my esophagus. That might sound kind of weird and scary.
Yeah.
Was it weird and scary?
No, it wasn't weird and scary. It was interesting. And like I said, I was curious.
Yeah.
But I wasn't frightened, and I noted to myself, gee, Peggy, you're not scared. I was like talking myself through it. And no, I wasn't. And that was astounding to me, because at one point the music stopped and everything was black. And that could have been a moment of extreme fear for me, but I was totally comfortable with it. And I don't quite know why or but I'm just really glad I was.
Yeah, yeah, yeah. Because say more. You're glad you were.
I'm glad I was comfortable with the black
Yeah.
hole that came on, and
Interesting.
it kind of taught me. It teaches me that I can face darkness.
Mhm.
I can face challenge
Mhm.
and not be so afraid.
Yeah.
Because when I had cancer, I felt like a kindergartner. I was so frightened.
Mhm.
Of course, it was during COVID,
Yeah.
so that added to the scare. But you know, I didn't feel like a kindergartner in the black hole,
Mhm.
which was empowering.
Yeah. Yeah. You look moved by that.
Yeah, I am moved by that.
Mhm.
I think that's something I can definitely take forward.
Mhm. Mhm.
And it felt like, could this be what dying is like?
Mhm.
Is this like what dying will feel like? Because it was so comfortable,
Mhm.
but there wasn't that bright light that people talk about.
Mhm.
But I thought, if this is what dying is like, I'm not so scared. I'm not frightened because this is so peaceful and comfortable. So that's a wonderful takeaway.
Yeah. Yeah, you get the drift. So, and as Rachel promised me, I'm at the hour mark. I'm going to go for just another couple minutes. Yeah, thank you. I think you know me better than I know me about this thing. Isn't that nuts, huh? So, just a couple of vignettes, and these are lines. These are literal quotations from our patients. So when our patients have the experience, I'm sitting by them as they're recounting their experience and typing this down. I'm capturing what they have to say. So here's someone who is so hard on herself through her experience with cancer, and she wanted to feel less self-judgment. So in the experience, this is in the medicine session, she said two people were crying, and she realized they were both me. She heard the crying. And when she realized that, she said, I felt pure empathy for the person crying, and I realized it was me. And what I took home from that, she said later, was caring for herself. Because in this weird experience of psychedelics, the sobbing that she heard, her heart broke for that person. And when she came to recognize that was her heart broke for her, and she could tend to herself in a more loving way than she had before. Fascinating. This person who's grappling with, how do I live in a body that's failing me? So this sometimes happens. This is a quote. I left this raggedy asshole body behind and went flying. And for some, it's just to be free of the body for a little while and to remember who they are, to remember joy, to remember flying, and then to return to the body. I mentioned the return is so powerful. For him, he returned and said, I want to live my life as long as I have left, not overcome with how little my body can do, how much it's changed. Death anxiety, boy, that's present for so many, facing cancer or not, but particularly facing cancer, waiting for the next scan, wondering what the future holds. And the question that often comes, how can I live until I die instead of dying while I'm still alive? And that's how so many people feel. How do I do that? And so what some will experience, like Peggy said, is having an experience of, for this person, playing in a pool of flowers. Now, this is coming from a person who had 5 sessions, who actually asked to experience the ketamine, to experience their dying. And they did after a few sessions. I can never guarantee that will happen. And it was very, very scary. One of the most scary things of their life. And yet, with some more processing, they were able to not be at ease with it, but less anxious about it and be playful around the reality of still having life in them, emerging ultimately saying, there are times I'm ready. I say to die, there are times I'm ready and I'd be good with it. This was a dramatic change for this person who came in saying, all I can think about is death. This person emerged saying, I can live some more. This person who talked of being fear bound, dominated by fear, waiting for the next shoe to drop, looking around the corner. How can I just be with less guarding, less pretending to be okay when I'm not okay? And for them, in the midst of the experience, they reported feeling lightness and heaviness at the same time, lightness and heavy fear. They actually also reported seeing their anxiety, seeing it, and realizing they weren't it. It was an aspect of them. It actually served them. It helped prepare them for difficulty. And emerged from this said, I lead my life without fear forward, is how this person described it. Parenting, loving, and approaching my work differently. Now, again, this is not a cure-all. This doesn't answer all the questions. It's not of the deepest use for everybody who comes, but everybody who tries this looks for something, and most people emerge with at least a kernel of possibility that they entered into not knowing if they could achieve. So whom is this for? The Pal-KAP program, and I should be clear too, this is not marketing. This is not a long commercial, truly. We're seeing patients. We have numbers of folks lined up. We can accommodate those who have a deep interest in them, and we're trying to make room. We have the philanthropic dollars to support me and a co-therapist. We always have two people in the room because we have people in that chair who deserve two perspectives, two loving presences, two hands to hold, two hearts to be in the room. And some people in that chair have experienced a range of traumas at the hands of others, sexual trauma and otherwise. We make this safe. The philanthropic dollars are allowing us to support this going forward. So how does one qualify? Serious life-limiting illness, or a strongly affected by serious life-limiting illness. Psychospiritual distresses we described as any severity of depression, anxiety, demoralization, grief, existential distress. That's most human beings. And this one's important. The desire and the ability to deeply explore personal questions. Somebody who says to me, I want to have a good time. I don't want to touch on the trauma. I say, let's not do this. This isn't going to be the place, because it's possible we'll touch on the trauma. Have to come in here open to all that you are, all that you've experienced, and we'll ensure it's safe for you and supported. Ideal but not required, I encourage, is conventional psychotherapy in addition to this. This is time limited, this is visits limited, and people who have a therapist to go to with the material might find some real benefit in that. Who may not participate? So if one has had an experience of psychosis, bipolar disorder, schizophrenia, I won't offer this because this can trigger that experience and it can destabilize whatever stability somebody brings in. Pregnancy and breastfeeding, even though ketamine is probably safe in those settings, we wouldn't want to risk it. Serious active substance use disorder or severe heart, lung, liver disease. We've taken care of plenty of folks with heart disease, a person with a heart transplant, lung disease, liver disease. So it has to be really severe. And the way to do it would be to have a clinician referral. It's really important to have clinician support. So somebody who has a nurse practitioner or physician or PA who has made the connection, who has sort of granted the connection. That's really important. It's not absolutely imperative, but it's important. So now time for conversation. We have 21 minutes to spare. Something like that,
Such a
okay?
wonderful presentation.
I'll stop share, okay?
Okay. That way we can see your lovely face a little bit bigger on the screen.
Well,
No.
that's what we all deserve, huh?
So
All right, there's my face. Okay.
we do have a bunch of questions.
Okay.
And if people have questions as we go, we can try and get through them. Drop them in the chat as they occur to you. We'll get through as many as we can in our 20 minutes. All right, number one. And you sort of touched on this a little bit, but I wanted to be explicit about it because this was a question shared in advance. If somebody is in active treatment for cancer, especially if they are on chemotherapy, does that automatically disqualify them from taking part in the Pal-KAP program?
Right. No, it doesn't. I would very much want to know, though, what is their experience of chemotherapy? What are the side effects from the chemotherapy? And I'd want to be sure that the chemotherapist, the oncology team are comfortable with this. I don't want to get in the way of the rhythm of the therapies. We've seen people while on active treatment usually separated to their best days. I had some, for example, every 3-week infusions, if those are knocking you down, if those are causing nausea and vomiting, we wouldn't want to do it shortly after that. We'd want you to be in your best shape. This can induce nausea in some folks. We've had one session out of 63 now, somebody who was getting highly immunogenic, nauseating therapy, who had a very, very severe vomiting reaction to this. So we want to be just really, really thoughtful. But no, that is not a rule.
Okay. A lot of folks are curious about cost.
Yeah,
Does your practice offer help with costs since
yeah,
most insurance doesn't cover this therapy,
right.
and it can be unaffordable without insurance
It
support?
sure can be. And Rachel, you and I have actually talked about this very thing because for those who don't know, Rachel is very much about equity and accessibility, um, and just care. And we have our hands tied in some ways, but I say with pride and also some limits within that pride is the way we've built our program is for accessibility, regardless of ability to pay. We do charge insurance for these visits. Insurance sees psychedelic-assisted psychotherapies as investigational, and so they don't pay for them in most cases. I am not hiding the fact that we're giving ketamine, but we bill insurance for a visit with a doctor. It's a medical visit, and I use what's called time-based or elements-based billing. So these are all insurance reimbursed, and every one of the sessions we've had here has been covered by insurance. The donut hole, as it were, in some cases, is early in the year, somebody who has a high deductible plan, it's going to cost you more upfront. It will. I can try to compress that within the bounds of law and charter agreements with insurance plans to make it less painful for those who are really limited by budget. In general, though, this is, I've had folks with means and folks without means, and as long as insurance is there, we can make it happen.
Thanks, Rob. Okay, then there's also some concerns about, there's two questions that are similar. What are the risks when a ketamine treatment takes a course of opening memories, like experiences of horror and trauma? And then the other question is, do people ever have bad
Yeah,
trips,
yeah, yeah,
through this ketamine experience? How is that
yeah,
handled? And
sure.
could the psychological constructs some folks use as a psychological defense be altered?
Yes. So yes to all. So um, there's a fascinating literature talking about bad trips, um, and what defines a bad trip. If by bad trip you're meaning difficult, yes. Most people during the experience will have some difficult, uncomfortable emotions. And I'm being careful about not using the word negative emotions. They're not negative. They are part of who we are. That includes the joy, the grief, the fear, the overwhelming fear that can serve us if it dominates us again, get in our way. People have had during these experiences, let me personalize it. I have had the experience with good guidance of feeling terrified in the middle of psychedelic experience with excellent guidance, I mark. And I share with you with confidence, with gratitude. I look back at those. I'm glad I had those. I learned a lot from them. If there's supportive guidance built in, my my assurance is we can find a way of handling what goes on. Can people re-experience trauma? Yes, they can. And if someone comes into the space and says, I can't go there, I honor that by saying, let's not do the psychedelic because our control of what happens, Rachel's heard me offer this, when I'm setting somebody up, um, we can set a course when somebody goes into the session, but ultimately our bodies, our minds, our souls, our spirits, our histories take us where it takes us. I'm confident that with two loving supports who know how to handle difficulty, and we do, um, it's going to be okay even if it's hard. And with processing and maybe more sessions, but not necessarily. There will be something of value in that. So that's a long way around saying bad trip in the common nomenclature had to do with a psychedelic trip in which one gets stuck in a thought loop and can't get out and feels like depression can feel, if you're familiar with this, of being stuck in an endless, hopeless pit. It can feel, I know the experience of depression in my body. It can feel like a kind of depression that is even more intense than depression at its worst base that I've experienced during the experience. And so, if well armed for that, and I don't mean defensively, I mean open to the potential for that, with arms down and with loving presence nearby, people can find a way of being with difficulty in a different way. That's a long answer to a short question. Can it be difficult? Yes. Is it dealable? Yes. Is it for everybody? No. And this is where your agency in saying, yes, I wish to try this or not stands. And I honor that fully.
I thought it was a really helpful explanation when you described it as, you know, these two loving presences, Rob and another clinician at your sides, help put you in the boat and launch you. And you can maybe have an idea of where you're going, what shore you're going to, but depending on the current or the winds, your boat may go, it will go somewhere,
Right,
but it might not go exactly where you thought,
right.
but it'll be somewhere important,
Yeah.
most likely. And you will also not be alone ever. So even if you experience hard things, you're not alone and you have two people who will hold your hands,
Yes.
which is a really beautiful thing.
Yes. Well, thank you for that. I'm going to use that next time.
Okay, it's all yours. All right, we had a question about how do we go about making an appointment for a consultation if we wish?
Yeah,
And you need an oncologist's referral. You did mention that having
right.
a clinician's referral is helpful but not essential. Is that right?
Right. So there have been a few people who self-referred. Um, it, it is, I have to be careful. So here's another place where I'm working in a community, there's a culture. I'm sensitive to it. I'm also a rebel against it, oftentimes, please know. And yet, so how to work in it reasonably, knowing that your oncologist may be my colleague. It's very useful. I'm very wary of proceeding with this without at least their knowledge and their begrudging assent, at least. Um, do they have to bless us and say it's the best thing in the world? No. Um, but I wouldn't want to do this against their better judgment if they think it's a compromise to your well-being. Um, so having a clinician make the referral is important to me. It also gets into it also, frankly, I am putting these into the visits into the electronic medical record. Um, I don't put a whole lot of detail into the notes, but I acknowledge we're giving ketamine. I acknowledge some of what this is for. I have to have, by the way, I have to have a mental health diagnosis in there so that I can bill for this. And so the kind of diagnosis we are, if you have a pre-existing mental health diagnosis, major depression or anxiety, we use that. If not, I use something called illness-related anxiety, meaning anxiousness in some way related to the illness or what it might mean, or adjustment disorder with depressed mood or anxiety, reasonable things that will not stigmatize you. So yes, it's really important to have um, collaborative agreement here to the extent that's achievable. So that would be my preference. If anyone has a firm no from your oncologist, I'd have a hard time moving forward.
Okay.
That said, I still see, here's where I'm of two minds. Um, I would still welcome your reaching out and I'll see what's possible.
Okay. Does that happen often? Like a firm no?
No, I actually have not. And I'm saying that, when I presented a policy, I think I told you this, Rachel. I mean, I use the word armed. I was prepared for a fight when I tried presenting this to the administrators here at U of R. And, so I'm an over planner. That means you're safe in my hands. That also means I'm prepared if somebody says no. I've not yet had a no, but I've had a couple people saying, I'm not so sure you're going to like that.
Okay. All right. That's fair. Someone also asked, are private pay visits possible such that there's no medical record?
Yeah, I can't do this without, I really have to, and this is to cover my butt as well as yours, frankly. I need to put this into the medical record. What the content of the notes, though, it will say ketamine. I can't deliver this without making a documentation about it. So, no, there's no way to go around that. Um, but if you wish to have a conversation, we can have off the record conversations. I've done that with many folks who just want to know about this, talk about this. I don't have to document that, that Joe contacted me and is curious about this thing, but is fearful you, Dr. Smith, are going to find out. So you can reach out if you wish to have conversation. That would be through calling the palliative care service. My greater preference really though is that you have clinician support for doing this, and then we can have our usual way of communicating.
Yeah. And there are some clinicians certified in the community, private
Oh, yeah,
clinics.
yeah. So, and I'm
Are.
not in competition with them. Yeah. So to speak to that, no, that's important to say. So there are multiple now CAP providers in the community, most of whom offer CAP sublingually, which works well. It's a different experience. It's a slower onset, but can get people to this great depth. People who are well trained, who are good clinicians out there. You can find them online. Some of them do use some insurance for some of the visits. Most of them don't use insurance for the medicine visit. There are some out-of-pocket costs for these, for the medicine, which is more than the pennies I described for our institutional use, um, for seeing a psychiatric nurse practitioner, typically in order to get the mental health clearance, and then for the visits. So there's a range in costs from many hundreds of dollars to thousands of dollars. And I don't say that to put you off or to say that's not worth your while. Do know if doing this through the channels I'm describing is not to your liking, you can find good practitioners out there in the community.
Yeah. And I might be able to follow up with an email with a short list.
Yeah,
Um,
I can share a few things
for
with
sh-
you, Rachel, and that
okay.
might be if you don't mind being the hub of that wheel, that would be good. I'll be a spoke and I'll get you some information with some of the practitioners I know. I don't know all of them in the community, but I know some of them, and I'm happy to share some names. The ketamine infusion, by the way, for people who want just the medicine. And that is useful for some folks who are grappling with depression. It doesn't include the therapy as a component. If you have your own therapist and your therapist or psychiatrist would agree that the infusions, usually series of these, 2 to 3 a week for several weeks and then spaced out, there are costs to those. There are two organizations in town that offer that. I can share that with you too, Rachel, if that were your interest. That's not this processing component. That is the medicine infusion.
Okay. It's good to know that there are options.
Hmm.
There were a couple questions about psilocybin because you mentioned and shared some of that
Yeah,
research, and it looks like it's a much longer trajectory, so it's harder to find places that offer that. But
yeah,
do you have any resources you could recommend for finding a trial or a center that
right,
offers
right.
psilocybin to the
So
same?
right. You can look on clinicaltrials.gov.
Okay.
You can type that maybe, Rachel, clinicaltrials.gov, and you can find there are multiple trials around the country. Um, Luke Papone here at the Cancer Center was going to do a psilocybin trial. I don't think that's off the ground yet. Um, In order to experience psilocybin, since it is still considered Schedule 1, again, I'm going back to the socio-political history that I mentioned. Um, um, there are legal risks, not tightly enforced. Some jurisdictions have illegalized or decriminalized or made legal psychedelics. This community is not one of them. There are, and I don't have, and this isn't me being sneaky pants. I don't have any easy way of referring you to anybody in town. There is the so-called underground that can offer psychedelics to folks. um, secretively. I don't have any straightforward or kosher way in my position to direct you to those. You could hunt and you could see and you could vet whether you think that's safe or not. There's some folks who know how to do that and some folks who don't. Um, that's the best I could tell you. But if you're looking for a clinical trial, which would be very safety conscious, not
Hmm.
necessarily better, but safety conscious, and that's really important. And it's important that I highlight that truly. Um, Look at clinicaltrials.gov, and you'll find numbers of trials out there for psilocybin, for ketamine, for MDMA, LSD analogs, and others.
Okay. Okay, two more quick questions. Hopefully we can get through them. Um, One participant is curious, how many, if any, of the people that you've seen um, have not had good results or the best
Right,
results that they were
right,
hoping?
right. So, it's interesting. As I mentioned, the paper that we're about to put out there, um, I am not, I don't write a lot of scholarly stuff. I like writing because hmm, I like more human story. And some of the confining nature of rigorous randomized controlled trials I find suffocating, important in ways. This is a long way around saying we decided early on not to track with any particular survey instrument how people are doing because people come in for lots and lots of different reasons. So to get to your question, people come for different reasons. Some because they want to understand their anxiety, some because they're dealing with who am I as a mortal, some who am I in this body that's changing. Everyone who has come through, I can say with confidence, has experienced something different than they have before with some take-home points, but I don't have an easy way of grading those. I tried doing that early on. I've got patient testimonials, and I would share with you as humbly, honestly as I can that of our 34 patients who've experienced this for 64, I think, sessions now, um, um, 90% have had a powerful experience that makes this very important to them. And maybe 10%, that's three, four, five, emerge saying, yeah, what's the big deal? Or God, that vomiting sucked, Horowitz.
Wow.
Or yeah, right. And that matters to them. Although that person looked back and said, I'm really glad I did that. So the vomiting sucked and that was useful for him. The more common thing is, gosh, that didn't really show me much. Um, I have not had anyone who emerged from this, and I don't know if this is the whole truth because they like me and they don't want to hurt my feelings. I've not had anyone come away saying, God, that I regret that. That was a waste of my time. But the degree of wow varied from moderate to very high. That's the best I can give you. And I'm not trying to hedge that. I don't have an easy answer. I am trying to get from my patients some testimonials so they can speak to you better.
That sounds wonderful. Okay, I wonder if we can get through this last one.
Sure.
How can we as individuals advocate for greater investment in mental and emotional health, both
Yeah.
by healthcare systems and support by insurance? Is there anything
Yeah.
you would suggest
Yeah.
for us as advocates?
Yeah, in our 1 minute remaining, yeah, I will tell you that our palliative care grand rounds today was by a psychologist who was a guest lecturer talking about mental health and its underinvestment and the difficulty in doing research and how limited the resources are for people with serious illness. So I validate the gap in care. I validate the reality that attention to your psychospiritual well-being is less than ideal. Um,
Plenty of room for improvement.
Plenty of room for improvement. That's really the best I can say because shaking up the medical system to up the provision is really, really hard.
Yeah. Well, we will keep on keeping on.
Yeah,
Thank you so much for your time and your expertise for sharing that with us, Dr. Horowitz. And thanks to all who were able to join us this evening. Thanks to our amazing interpreters. And our next webinar next month is about spotting pseudoscience in healthcare headlines, which I would say is increasingly relevant to help us all find trustworthy information in the chaos these days. So if you're interested to learn more about gaining some tools for information safety from a nationally renowned healthcare journalist, Gary Schwitzer, please join us on February 25th. And until then, wishing you all warmth and good health, and hopefully we'll see you in the world. Take care, everybody. Thanks again, Dr. Horowitz.
Great, thanks. Okay, good to see you. All right, bye-bye.
Bye-bye.